I thought this one.
Good morning, everybody. Today I'm presenting Sanet Supra. Sanet completed her B.Pharm degree in 2007 at the Northwestern University. She went on to complete her postgraduate studies, MSc Med in Clinical Pharmacy in 2016 at the Pharacokinetics Health Sciences University. Sanet then joined Mediclinic Midstream in 2015 as the clinical pharmacist and is still currently here. She is an active member of the South African Society of Clinical Pharmacists, SASOCP, and had the privilege to present 2 posters at the 2023 conference for the society. Sanet remains a lifelong learner with a passion to improve patient outcomes as part of the multidisciplinary team. We are very fortunate to have you on our team, and we are excited to hear your presentation.
Thank you so much, Leah. Okay, so today I'm just going to take you through the practical approach of pharmacodynamics and pharmacokinetics in practice. Okay, so just a bit of background. So to optimally treat patients with sepsis, it requires a prompt administration of antimicrobials as well as precise dosing to achieve therapeutic concentration at the target site and yield both a clinical and a microbiology effect. And then we also want to prevent toxicity. So PK/PD plays a vital role in precision dosing in patients. So when we look at the definition of pharmacokinetics, it's what, in simplified terms, it's what the body does to the drug. With pharmacodynamics, is what the drug does to the body. So when you refer to the dose of the drug that's administered, it goes into the body. Then the drug concentration in the systemic circulation is distributed amongst the tissue, and if it's a 2-compartment model, it will go back into the bloodstream. And then the drug also gets metabolized and eventually it's excreted. Then at the drug concentration site of action, you've got a pharmacological effect, a clinical response, and then you either have effectiveness or you have toxicity. So in precision dosing, we want to reach effectiveness and avoid or prevent toxicity. So when we look at the pharmacokinetics for absorption, your IV administration is usually rapid. So that's your preferred method in patients with sepsis. And then that also can give oral, but we don't preferably use this in an ICU or critical ill setting because although it's got a good bioavailability, it might be lacking in systemic concentration when it's taken. Then we look at distribution. So you need to have tissue penetration, and it's very important, especially in antibiotics, where you want specific antibiotics to reach a specific tissue or a specific site within your patient. Then metabolism. This is now our great source of drug-drug interactions. It takes place mainly in the liver, and that is why it's also important when you do have severe liver impairment to look at dosage adjustments. Then finally, we have our excretion. Mainly our antibiotics are excreted renally, and there is a bit of a conundrum when you have renal impairment in a patient with sepsis. You'll look at acute and chronic renal impairment, and then patients that are critically ill are also tended to have augmented renal clearance. So they clear the drug much quicker than your patient is a healthy patient, and it also needs to look at increasing the dosage of patients with augmented renal clearance. So we've got antibiotics, specifically that we are looking at other drugs as well, but we will focus on antibiotics today, where you have a 1 versus 2 compartment model. So to make it practical, we look at amikacin as a 1 compartment versus vancomycin as a 2 compartment model. So amikacin you will administer IV, it will directly go into the bloodstream and then get excreted via the kidneys. Vancomycin is a bit more tricky, and we call this a hybrid drug. I will elaborate on the hybrid drug a bit later. So it goes into the blood, then it goes into extracellular, and then it goes back into the blood as well. That's why we will see if you've got dosing one day after the other, it can accumulate and have higher levels. That's why it's important to also take your trough levels, or these days it's more trendy to take steady state levels to ensure that you don't reach toxicity in your patients. So factors that influence distribution is fluid shift. So if you've got a patient that's very edematous or they have ascites, that impacts your volume of distribution of your hydrophilic drugs. Once again, I'm going to use the example of aminoglycosides and then also your beta-lactams. So that means that your drug will move out of your bloodstream and into the extracellular fluid because of the affinity for where the water goes, the drug will go. And then your hyperalbuminemia may also significantly affect the concentration of highly protein-bound drugs. And we'll look a bit more at protein-bound drugs later. That's why it's very important when your patient has an extremely low albumin and then sepsis that you need to supplement and ensure they also get the nutrition to build your albumin. In metabolism, as I've mentioned before, the liver plays the largest role in metabolism of drugs. So you've got a phase 1 metabolism. It includes oxidation, reduction, and hydrolysis reactions, whereas conjugation is classified as a phase 2 metabolism phase. This is the cytochrome P450 enzymes, and they are primarily responsible for the phase 1 metabolism. And then we have your drug-drug interactions, especially like a class of azoles that will interact with a lot of drugs. In excretion, so as I mentioned before, most antimicrobials are renally excreted. And then you will have patients with renal impairment, acute kidney injury, and you will have patients with chronic kidney injury, and then you will have patients with chronic kidney injury with acute kidney injury upon that. And then you will also have augmented renal clearance. As I mentioned, that they clear the drug much faster, so you have to look at your dosing. And then the severity of infection and the timing of the acute kidney injury also plays a role when you need to look at dose adjustments. So another concept that we also need to keep in mind from all the pharmacokinetic aspects is the pharmacodynamic aspects. So you've got antibiotics, which is concentration dependent killing, and then you've got time dependent killing. So as concentration increases, its extent of bacterial killing increases, and the goal of therapy is to maximize concentration of drug exposure. Once again, aminoglycoside features here. And then your time-dependent killing, the longer the duration of exposure, the greater the antibacterial activity. And the goal of therapy is to optimize duration of drug exposure. And here we look at your beta-lactams. So the pharmacodynamic concept is what the drug does to the body or to the organism. So when we look, it's very important to, in combination with your PK/PD parameters, look at your administration of the antibiotic. So you will want to have, with your concentration-dependent drugs, a nice and high peak concentration above the MIC, and then it will taper down so it will, the level will come down so it will not be toxic. Whereas with your time-dependent antibiotics, you want to be your time of exposure extended, like your beta-lactams, your clindamycin, linezolid. And then the hybrid drugs that we talk about is your area under the curve drugs, where you want an exposure of more than 24 hours versus also the time dependency. So it's a time and concentration dependent administration requirement. So when pharmacodynamic measures correlate with the efficacy, as you can see, just to summarize what I've just mentioned. So with your time-dependent antibiotics, where you want to keep your time above MIC and maximize your duration of exposure, you want frequent administration or prolonged infusion dosing, and this will be dependent on your stability of your drug. And then with your concentration-dependent drugs, you want your Cmax or your peak level to maximize the concentration, so you hit hard, and then usually this is a once daily dose, and then we'll do it according to trough levels. And then your concentration dependent with time dependent, your hybrid drugs, you'll have to maximize the amount of drug exposure and administration of high total daily dose. So as I mentioned, your hydrophilic antibiotics, which is your beta-lactams, referring to your penicillins, your cephalosporins, your carbapenems. So here we look at doing a loading dose, and then directly after that, we'll do a continuous infusion dose. And although there's been a lot of controversy that there's no benefit, or the benefit isn't outweighed when you use continuous infusion versus intermittent infusions, a later systemic review actually and meta-analysis shows that there is a significant benefit of doing continuous infusions, not just from a nursing administration point of view where you have less missed doses, but if they look at the long-term mortality, there was a decrease of continuous infusions versus intermittent infusions. And then also, it's very important extended infusions of carbapenems over 3 to 4 hours, depending on the stability. That also makes a significant difference when you've got a resistant organism and you need to use your carbapenems as your almost last line of administration to treat the sepsis in the patient. Then linezolid is also shown a benefit to do a loading dose over 2 hours, followed by a 600 milligram BD infusion over 12 hours continuously. As you know, this to get you that area over the curve above MIC for 80% of the time. And then we also do, although it's a hybrid drug, the vancomycin, it's training now to do a loading dose and then to do a continuous infusion. That also just helps to prevent Redmond syndrome because you've got a longer infusion and you've got both the exposure time above MIC and area under the curve. And then just to remember, beta-lactams do have a short half-life, so they get eliminated much quicker. So that's why it's also beneficial to do a continuous infusion or extended infusion. And then at the bottom, you just see with meropenem, they've done a Monte Carlo simulation. So this is one of the programs that they use to simulate the drugs. Obviously, in your critical ill patients, this might differ. So then optimal dosing of concentration-dependent antibiotics. So it gets tricky when you have high MICs and you've got resistant organisms because you want to hit your Cmax or your peak concentration 8 to 10 times above the MIC. And then it's very important to monitor the trough level to reduce toxicity because now you're going to dose extremely high in order to treat the severely resistant organism. Okay, then therapeutic drug monitoring. Unfortunately, it's not always possible, but we are seeing a trend where more and more labs are doing levels, and then you just need to know how to interpret them. So therapeutic drug monitoring is the clinical practice of measuring specific drugs at a designated interval to maintain a constant concentration in patients' bloodstream, thereby optimizing individual dosage regimes. Therapeutic drug monitoring involves not only measuring drug concentrations, but also clinical interpretation of the results, as I mentioned. And this requires knowledge of the pharmacokinetic sampling, time, drug history, and the patient's clinical condition. Okay, then dose adjustments in renal impaired patients with renal clearance. So patients with sepsis optimize the first. So if we look at giving the normal dose in the first 24 hours, then in ICU up to 48 hours, depending on the scenario. And then we'll do a dose adjustment based on either the eGFR or the creatinine clearance. So the creatinine clearance we usually calculate by using the patient's weight. Depending on the drug, it will be either the ideal weight or the patient's own weight. And then we'll use a constant depending on male or female. And then you will use the serum creatinine that was measured by the lab. Okay. So as you can see, most of the drugs on your left-hand side is excreted renally. So that's the ones that we mainly use. And then to your right-hand side is the ones that are, you don't have to dose adjust because they're excreted by the liver hepatically. So when you've got your general PK versus your altered PK in the, ICUs, you'll see that in the general population, your hydrophilic antimicrobials, you usually have a low volume of distribution. So there's low intracellular penetration and predominantly you've got good renal clearance. If you're lipophilic antimicrobials, you've got a high volume of distribution. There's a high intracellular penetration and predominantly it's hepatic clearance. Then when you have a patient altered that's in the ICU, you will have an increased volume of distribution because, as I mentioned, at the edema. So your clearance will depend on the patient's renal function. So it can either be renal impairment or there can be augmented renal clearance. And this decreases the interstitial penetration, where with hydrophilic drugs, your volume of distribution remains more or less the same. Your creatinine clearance can either increase or it can decrease, depending, or your clearance can increase or decrease depending on your hepatic function. So either if you have liver failure or there's liver impairment. And then just once again, when you look at your different antibiotics, your hydrophilic drugs, your aminoglycosides, your glycopeptides, your linezolid, filicin, and fluconazole, where your lipophilic drugs is your fluoroquinolones, your macrolides, your licosamides, and tigecycline. So just in summary, everything that we need to look at when we look at the drug, so you will classify it as either a hydrophilic or a lipophilic drug. Look at your volume of distribution, then see if there's renal clearance impairment or hepatic clearance impairment, and then you will adjust your dose with the critically ill patients, saying the loading dose that you need to maybe increase, or your maintenance dose of renally cleared antibiotics to increase or decrease according to your renal function. So in acute kidney injury, there's obviously dose reduction, but we also need to balance that with the patients that have a severely resistant infection. So obviously, if there's normal renal clearance, then you don't have to adjust your dose and augment it, you have to increase your dose. Then in lipophilic drugs, there's no need to increase your loading dose. Your maintenance dose need to be adjusted only if there's severe hepatic failure. So that's the worst case scenario. And then I forgot to mention, your therapeutic drug monitor guides your dose optimization. It assists with your optimal PK/PD parameters, and it helps to potentially improve outcome and decrease risk of antimicrobial resistance. When you select a drug, it's also important to remember your choice of antibiotics so it will reach your target site. It doesn't help you use a drug and it won't reach, for example, your CSF. So that's also a factor that you need to include when you're making your decision along with your PK/PD parameters. So basically, the take-home message is antimicrobials should target the pathogen at the site of infection. You should ensure adequate target tissue penetration, consider physiochemical properties of antimicrobials in severe sepsis, understand your PK/PD strategies to optimize the therapy. Adjustment in renal impairment patients should be individualized as per the scenario. And then there's a very fine balance in treating multi-drug resistant organisms in patients with renal that requires renal adjustment. And that's where repeated drug monitoring is very handy if you have the levels within the bloodstream. Okay, and that's just a summary of everything that impacts your dosing. So the factors that influence antimicrobial dosing is your patient factors, your antimicrobial factors with the solubility, your volume of distribution, your protein binding, drug clearance, and then at the end of the effect, then your microorganism factors is your MIC values, and then obviously there can be a laboratory variability where it depends on when the dose was taken, if it was a random dose versus a specific trough dose versus a specific peak dose. And then we unfortunately don't have the dosing software in South Africa yet. I know they use it abroad in Australia. They've got great data on it. It's quite expensive, but hopefully in the future we'll also get that. And this is just it impacts that we get better clinical outcomes, reduce toxicity, and prevent antimicrobial resistance. So although you have a very resistant organism, you can still use your current antimicrobials to optimize your patient's treatment. Okay, that's just my references. And then thank you so much with any questions.
Thank you so much. This was quite great presentation. Yeah. So I just midstream we struggle quite with a few issues. Mine's about loading dose. Another question that who should be getting loading dose? Is it the beta-lactamase or is it the others? And what's really the benefit of loading dose?
Okay, so definitely in your beta-lactams, you will give a loading dose, and the benefit is that you will get the concentration to the level in the patient that you need to have that killing, as I've mentioned. And then you cannot wait hours to start your next dose. You have to give you a continuous dose directly after. So, for example, if the person has a bacterium, we'll do a loading dose over 30 minutes, and directly after they can hang the, either if it's a normal renal patient, 18 grams, they run it in 200 mils over 24 hours, and then the sisters just ensure that they mix the next dose every 24 hours so that there's no interruption. With your beta-lactams, you will also do a loading dose, and then also advise the sisters, say, for example, you give your loading dose at 9 o'clock in the morning, you will slot in your next dose in your, which is usually your ward times at 2 o'clock, and then the next at 10 o'clock, because you don't want your following dose, your second dose after the loading dose, to be more than 8 hours. Otherwise, that also defeats the purpose of the loading dose. And then with vancomycin, you will also give a loading dose, although it is a hybrid drug. But you will run it over longer hours, over 3 hours, to prevent Redmond syndrome, and then you do the maintenance directly after over 24 hours.
Yeah, I think loading dose is very important. I think, as Sanet has explained, it's giving that starting point where because you assume that if you're having like septicemia, you want to have a very good concentration of drug actually to control the sepsis before you start running your infusions or because whether it's infusions or QNE drugs, but at least now when you start your next dosage, you find that, let's assume you start at 100%, or once you start your proper treatment, you probably drop to 60%, then you maintain that level without dropping down and increased resistance. So I think we struggle with that in our wards, ICUs, and all that, because people do not understand the need of the loading dose. And we seen the scenario where somebody get a loading dose, then next time the dose is given the following day, and the purpose is defeated. Because if you have waited for more than at least 8 hours, then that loading dose is non-existent. You have to redo it again. And that's really how it's supposed to be done. So it must be done immediately, the next dose must proceed within 3 hours. And then, of course, for 24 hours, the drugs that are given daily, now sometimes we give the loading dose. Now, that's completely like assume the drug is given in the morning and you're given the starting dose at 12 o'clock. So that means, yes, your next dosage, you can start at 6 o'clock in the morning because they got a longer half-life. Okay. So you don't need to give up immediately, like, say, 6 o'clock. Again, you can increase overdose like vancomycin. If you give a loading dose now, and then let's say 2 grams, and if somebody got an impairment, and then you repeat the dose within 2 hours, you can have toxicity. So I think that's what we need to people need to understand that. And I think I think time to needle is very important how you treat patients. Yeah.
It starts with the doctor prescribing it the correct way,
yes,
on prescription, and then it being carried out.
And then the next actual claim. But I think actually should be easier, because I think if you have a system now with AI, you should have a scenario where actually the doctor prescribes, the pharmacist pick it up, and the nurse pick it up. You have to have because that time actually you can control it, not like in the past. Because like midstream, if you prescribe medical work, what the nurse need to do is just put it throw it through the healthy circulatory, you throw it, you don't need to walk to pharmacy, straight to pharmacy, and pharmacy immediately back. So ideally you could actually get everything within 30 minutes to an hour.
So, but we don't have that system.
We do.
Do we have it?
We should. The only thing is you cannot send glass vials.
Yeah.
But I just think from a practical point, even if you prescribe something, you have to be like a tyrant to get the medication to the patient. That's what I see in the ward from a practical point. If you have to now take someone off the floor to take it to pharmacy, to make sure that the medication comes back, then to mix it, then to give it to the patient, and then to remember to give the next dose. I mean, it's a schlep if there's only one sister. So that's what's happening.
Yeah,
There's only one that can actually give the medication. So it's an absolute waste of time that we're seeing in the wards. And I think that's part of the problem. It's not just the not understanding that the patient needs another dose. It's the fact that there's literally no one that can give 10 patients the second dose.
Yeah, I think that's, you're 100% sure of that. because most of the hospital groups are really, they're more geared for saving costs. And the nurses are more, they don't really allocate nurses. The nurses are allocated only when the patient in the bed, but they don't anticipate that patients are going to be coming. So sometimes having one nurse for 10 patients because they're only 10, but now when another 10 patients come, now the same nurse must nurse the 20 patients with the same. And I think also that's unfair on the nursing and then the demands on the nursing staff. Yes, I think that's the thing. But also I think the pharmacist has been assessing quite a lot in terms that most of the drugs are mixed and most of the status actually available in the ward already. And that ideally should be given immediately, you know, and yeah, but I think with that some that management need to come to the table with that and assist that we can increase our needle to time to needle sort of treatment. Yeah.
I think that is other problem is this delay in admission of the patient due to medical bed issues, bed restrictions. Then a patient spends maybe 4 or so hours in the emergency center, and I think sometimes, especially the sick patients, the nursing staff, you know, is geared to emergency treatment, but then you actually need to initiate your ward treatment on top of that in the emergency department, and I think often that is lacking just because of the staff issue, and they're not orientated towards ward management.
So a bit of resistance.
So,
A bit of resistance, and I'm
well, I think it is.
subordinate.
Yes, I think it's a component of both. Yeah.
I think the important thing you mentioned, which struck me, is it's another reason why edematous patients tend to do worse in ICU. It's affecting the way the drugs are distributed, and therefore the activity of it.
Yeah, I fluid management I see is very critical, and that's why I think in the past we have thought that patients need fluid, and I mean I remember very good teaching with Prof. Richard that when everybody's edematous means somehow they're not intravascular fluid depleted. So, but mentally, we normally look at these patients because they have low blood pressure, and we give them more fluid. And the problem that, of course, you have a lot of the capillary injury with extravasation of fluid, low albumin, so they have to be reasoned for it. So some of these patients require anatropes, and somehow they require your antibiotic adjustment is very, very important, you know, how you treat them, because, I mean, you have to also find the cause of low albumin in these patients. And if the low albumin is an issue, because most of the drugs are really albumin bound, you know, and that means you're reaching your targets is a problem. And again, obese patients are going to be a big challenge also, hard to distribute them. That's why it's very, very important actually to know what does a patient needs and what is really needed. And I think with the edematous patient, I think we have improved quite a lot, but you still sometimes see incidents in ICU where patients become overloaded. But most of the time we're very conscious aware of that. So fluid overload is something that we need to manage with Lasix and obviously make sure that does not become occurrence. And that will affect a lot of the drugs, of course, transportations and also your outcome. But not forgetting about translocation bacteria because of the edemas, and you know, and that's so the list actually goes on.
Don't mind your job because there's a lot of stuff happening. I mean, by the time you get a septic patient, to be honest, I mean, it's already a patient that is at baseline on a lot of other treatment. So you also have to think about those interactions. So Sanet, no wonder she must be going to witness clinic. There's a lot of stuff to actually think about when you see these patients.
Yeah, I think people don't understand because people think it's just like you're modeling around in ICU, but truly that I think there are a lot of thoughts put in place. You require a lot of knowledge, a lot of understanding, looking at other things, because you're not only managing, I always say running ICU is like actually being a driver. You have to manage the driver ahead of you and the one behind you and your car. And basically in ICU, you need to make sure that the nursings are doing the right thing, your colleagues are doing the right things, medication given thing, and also you have to look at the patient as such to kind of get to the answers where you wanted it to be. And yeah, and that's why mortality used to have very, really high. When someone starts taking mortality is quite high, it goes to about 50 to 60%, sometimes even 100% mortality. But I think with advent of the survival sepsis guideline, and for those who of course having ears to listen and also brain to contemplate the changes, and then how to manage fluid things have changed because the fluid management is absolutely very important on those patients. And also, of course, and that's having roles how your antibiotic actually attack, and then how your septic markers coming, your septic markers respond.
I think it's also about sort of always anticipating, because by the time you see something, either clinically or on your blood results, you already behind.
Exactly.
It has already happened. So you always have to anticipate what is the next thing.
Like we're always playing catch up game.
Yes.
But thank you guys. I think it looked like we started quite very well, and I think the years ahead, but I think it's positive mode. Presentations have started, and I think, so let's spread the good news out there and then get more people to get involved online and carry on with the teaching. The program's really, really doing very well. I think we're almost approaching 900 viewership, and most viewership actually took place in December when nobody was really, people are off. Yes, because people are bored. Actually, because a lot of things slow down, so they actually tend to now educate themselves. So I think we're at the right track. We must carry on and increase the number of presentations. And those who have previous presentation not recorded, please feel free to record it. You can speak to Marona and you can record in comfort of your own house or whatever you can, and then at least can go to the podcast. And I think really it's making a lot of difference. And the aim of the program is really to equalize education around Africa and around people that they have access to, because the resources remain the same, the knowledge remain the same. And I think that probably saves life out there. We can't save everybody, but at least give other doctors to do the right thing, and I think for me that would be the spirit.
Thank you very much.